My name is Peter Schneider. I'm a vascular surgeon at the University of California at San Francisco. The trial that I'm talking about is the PROMISE 1 trial, which is a study of percutaneous deep venous arterialization using the LimFlow system and the 1-year outcome of the trial. The concept of deep venous arterialization is one where, okay, the arterial system is completely obliterated. It's occurred over a period of many years due to a complex set of medical problems. But paradoxically, or maybe, just sort of almost accidentally, there's also the venous system that's there that is typically unaffected by these problems. There are patients that have vein problems, but this particular population, very, very often, their vein system or venous system is preserved. And so the question then comes up, is there a possibility that we could just reroute the blood supply into the vein system or venous system of the foot and bring blood to the tissues using that method? And this has been proposed many, many years ago, actually over 100 years ago, but it's never really been actualized because we haven't had a straightforward way to do it that could be done safely. And especially in this patient population, many of whom are at high risk for open surgery and other types of threatening procedures. So this concept then of rerouting the blood supply from the artery system to the vein system, bringing blood to a foot that otherwise you'd have no way of saving, and doing that using what we call percutaneous techniques. That is, um, do it in using essentially a keyhole type approach where we haven't made big incisions and the patient completes the procedure with new blood supply to the foot that we never thought was possible. And I'll just say that this population of patients, the so-called no option for revascularization, that is, patients with the small vessel disease in the foot, the likelihood of them still having their leg on a year later appears to be somewhere between 0 and 30%. So, in other words, the vast majority of these people will lose the leg within a year. And that's the problem that we're addressing. That's why deep venous arterialization, especially done in a percutaneous manner, is so important. And that's why we think it could solve a problem that we have faced for many years, a problem that is getting worse due to the growth of this group of patients that I mentioned, and one that has been incredibly frustrating for us as vascular or blood vessel specialists, um, due to the futile nature of trying to save these legs. And suddenly we have a solution on the horizon. So it's extremely exciting. Yes, the rationale for the PROMISE 1 study was to assess the feasibility of percutaneous deep venous revascularization or deep venous arterialization in a patient group that had no other options for revascularization, and to do it using a specific system, the LimFlow system, and also to do it in a manner that was in conjunction with, or a trial uh, approved by or developed in conjunction with the FDA. The PROMISE 1 study is an early feasibility study, essentially, um, which means that it is accepted or approved by the FDA as a reasonable option to test a new technology within the confines of the United States, in the hopes that if the trial then shows that the procedure is safe, is feasible, is has at least some potential promise of efficaciousness, that then the additional studies will be done after that. Yes, the design of the Promise One study, this included patients that had only Rutherford 5 or 6. That is, they had to have an open wound to be included, and they had to have no option CLTI. And the way we determine no option, because this is a concept that has some gray areas around the edges, is that we have an independent committee of vascular specialists review and approve every case. The endpoints that we focused on were amputation-free survival, but there were important secondary endpoints such as procedure and technical success, wound healing, and patency. The follow-up schedule is relatively robust, and even though this is an exceedingly high-risk population that is typically destined for amputation in typically a period of months, these patients will be followed up for 2 years, and with this will include wound assessment and hemodynamic assessment. Well, as I mentioned previously, that our primary endpoint was amputation-free survival, and the amputation-free survival at 6 months was 74%, and at 12 months was 70%. And I think this is obviously exceedingly important based on the idea that these are patients that typically go on, the vast majority go on to amputation within 6 to 12 months. And within that concept of amputation-free survival, there are components of survival and component of freedom from amputation. And in this population, we did have a mortality rate a little bit less than 10% at 12 months. So the actual freedom from amputation at 12 months was 77%, which I believe is extremely important for a couple of reasons. One is because this is the patient population which ordinarily the vast majority, possibly all, would have gone on to amputation. The other is that this is a relatively new system, the LimFlow system. And within this trial, we learned a tremendous amount about patient selection, technical aspects, which patients might or are likely to require a reintervention of one type or another. And those components that we learned are all things that could potentially then improve the results of a similarly done patient cohort in the future. Well, the next steps then, the early feasibility study, as I mentioned, is for a new technology that is hoping at some point to be well developed enough so that it would be approved for broad usage. So the next step is more data. The Promise 2 study will now enroll and is enrolling and is a pivotal trial intended at the completion of it, if it does show safety and efficacy as the Promise 1 study suggested that it would, the Promise 2 study would lead to the potential for FDA approval. And as I say, that study is currently enrolling, the pace is increasing as the number of centers and the number of sites get up and running, and this technology becomes better understood, and the patient selection then becomes more refined. And it's an extremely exciting time for this concept of deep venous arterialization. As I mentioned, it was suggested or introduced or talked about over 100 years ago, and now it's actually coming to fruition. It's extremely exciting for this patient population.